feel we'll cover the diabetes كويس what types of insulin وكده and then we'll send you a paper عشان لو عندكم أسئلة عنه كويس you ask me كويس in the next session ونواصل مرة جاية في الثايرويد والother topics دي حتى لو covered by anyone else person ما بكون عندكم مشكلة يعني هي common topics حتى الدايابيتس common لكن في أشياء معينة في الدايابيتس needs to be stressed بس وهي common areas of questions I think استجابة لاقتراحكم الأول رأي دكتور محمد نديكم على الدايابيتس شوية طيب right okay طب قديم ذاته كنت I was assistant at that time نشيل ده برا
You can make السكرين full screen يا دكتور.
sure معلش طيب that's it okay clear كده
Yes we can see it.
ممتاز طيب خلينا أشيل دي برضو تحت كده طيب okay if we talk about type 1 diabetes طبعا this talk is mainly about the management كويس about the treatment هيكون diabetes طبعا is one of the metabolic disorders has multiple etiologies and characterized by chronic hyperglycemia, disturbance of metabolism of carbohydrates, fats, and protein. Well, it is due to problem with the insulin secretion or action or both. Yes, insulin secretion or action or both. It's a biochemical diagnosis beside clinical. So there are criteria to diagnose it. Either you diagnose it by the fasting glucose or using the 2-hour postprandial or the A1C. طيب. وعندنا pre-diabetic states. The pre-diabetic states are impaired fasting glycemia and impaired glucose tolerance before you have frank diabetes. You need to be familiar with the millimole versus milligram per deciliter. كم بيساوي كم؟ 1 millimole بيساوي كم مليجرام per deciliter؟ اكتبوا في الشات 18 that's right. Okay, so when we say good, yeah, good. So when we say 11.1 millimole, that means 200. Yes, for the patient who have diabetes will have blood glucose above 200 milligram per deciliter, 11.1, and the fasting glucose above 7, which is 126 milligram per deciliter. But this is a common question you are asked about من الببليكس يسألوكم متى أقول إنه ده diabetes. ده إذا كان random above 200 milligram per deciliter or 11.1 millimole, or the fasting is above or equal 7 millimole per liter or 126 milligram per deciliter. طيب النورمال إنه يكون الراندوم less than 7.8 معناها النون diabetic ممكن بعد heavy meal مثلا sugary meal can go up to 140 milligram per deciliter. طيب إذا كان upper limit في 2-hour postprandial is the patient is at this level فالفاستنج glucose المفروض يكون less than 110 في non diabetic. إذا patient في patient between 110 and 126, that means this is a patient in an impaired fasting glucose status. وإذا blood sugar after meal goes above 140 up to 200, this is a pre-diabetic having impaired glucose tolerance. That means he cannot tolerate a heavy meal with glucose. Yes? فإذا الأرقام دي تكون واضحة عندكم. Less than 110, yes, this is usually normal in fasting state. Between 110 to 126, this is impaired fasting glycemia. Above 126 as fasting, this is diabetes. Above 140 to 200, this is impaired glucose tolerance. 126 to 140, this is normal postprandial. Above 140 up to 200, this is impaired glucose tolerance. Above 200, this is diabetes. واضح كده؟ البلود hemoglobin A1C. طبعا دي ارقام مكتوبه from different references لكن now we use 5.8 above 5.8 يعني 5.8 or 5. من 5.8 and above لحد 6.5 this is pre-diabetes. Less than 6 less than 5.8 this is non-diabetic. هي حاجه less than 5.8 في ال A1C non-diabetic 5.8 to 6.5 less than 6.5 6.4 يعني this is impaired أو pre-diabetic state سواء كانت impaired fasting glycemia أو impaired glucose tolerance. Above 6.5% this is diabetes. هو ده هنا. طبعا you cannot use hemoglobin if there is hemoglobinopathy. So if the patient has got hemoglobinopathy you use what؟ واحد يقول لنا ايش you can use؟ Excellent عايشة. Fructosamine. Fructosamine is another type. But fructosamine, how you use it is more difficult question. You use it every 2 to 3 weeks, ما every 3 months. Okay? So in short duration بتغير. الحاجة الثانية طبعا this is depending on what is attached to the hemoglobin. يعني حتى ال A1C انت بتستخدمه كيف؟ What is attached to the glucose I mean sorry. Fructosamine get attached to the glucose دي الهاف لايف بتاعته. فلأنه الهاف لايف بتاعت الهيموجلوبين 120 days that is come out of ruptured RBCs عشان كده انت بتستخدمه في 120 days. فلو كان عندك هيموجلوبينوباثي use fructosamine في tables بتوريك this level of fructosamine is equivalent to which percentage of A1C. هسه ال A1C نفسه الآن بيستخدموه بالبرسنتج أو مليمول تو مليمول. كويس؟ مليمول تو مليمول as a reference النورمال 57 or 56 point something. المستخدم في يوروب in order to benchmark your findings with other centers. لكن الكومن use percentage. طيب الآن نشيل كده aside. طيب symptoms of hyperglycemia and findings of this based of any of the things in the bottom here will diagnose diabetes. So it's a biochemical diagnosis. Well, usually you need consecutive readings, so 2 of the fasting readings instead of 1 to make the diagnosis. Like if you have the symptoms and you have 1 of these readings, this is diagnostic of diabetes. However, if a patient receives corticosteroids or any other hyperglycemic treatment, this can result in what we call incidental hyperglycemia. Incidental hyperglycemia. طيب واحد كده يجاوب السؤال ده شوف انه فهمكم في الديابيتس كيف يعني. هل الأقرب لأنه to develop frank diabetes impaired glucose tolerance ولا impaired fasting glycemia؟ fasting. واحد قال impaired tolerance. GTT يعني impaired tolerance قصده. GTT fasting. مين اللي بيقول fasting؟ كويس أول واحد قال fasting خلينا نشوف. أول واحد قال fasting. أول ما اختار fasting صفاء موسى تبين. طيب أدي صفاء فرصة يا محمد تورينا ليش fasting أو إناث للثانية أو تنزيل. مين عاوز يشرح لنا ليش الفاستنج هو أقرب؟ ما في حد يمكن بعيدين. anyway طيب الفاستنج هو الأقرب صح الرايت. وذلك لأنه يعني if you are not able to keep the blood sugar during fasting state optimum, that means your insulin secreting capacity is getting very limited. But if you have failure to do this with a glucose challenge, that is a lesser stage or milder stage of risk of diabetes compared to fasting level. Impaired fasting glycemia is more near to develop frank diabetes than impaired glucose tolerance. impaired glucose tolerance هو اللي بيحصل مع ال OGTT. Good. طيب type 1 diabetes, type 2 diabetes, gestation and other types of diabetes. طبعا الأسماء القديمة insulin dependent diabetes mellitus, juvenile, it's autoimmune, idiopathic. This is defining it by the cause or the etiology. Like in the popular and the correct and the most recent one is type 1 diabetes اللي هو ده أكثر حدوثا في children, juvenile, وهو insulin dependent. Yes, it's true. لكن we have type 2 diabetes when in the last resort become insulin dependent as well, when they have their pancreas is not functioning completely. So it's not true to call it non-insulin dependent. لكن هو أكثر في adults. And also we have MODY, which is a maturity onset of diabetes in young. So that's why the adult and juvenile is not a popular or good classification or fair one. Insulin, non-insulin dependent is not a fair one as well. So the triad of type 2 diabetes is to have this triad of family history, obesity, especially abdominal obesity, and acanthosis nigricans. But you can have it also in lean body mass patients. Gestational diabetes that occurs in pregnancy. And then the MODY or the monogenic diabetes, congenital neonatal one, is part of it. And then we have secondary diabetes that occurs because of excess of counteracting hormones to insulin, such as cortisol in Cushing syndrome, thyroid hyperthyroidism, or any other source of counteracting hormones. So the basic pathophysiology of type 1 diabetes is to have it, to have some susceptibility, genetic susceptibility, so genetic contribution, and then you have a trigger like virus or toxins or diet, certain diet, that triggers the immunological process, which leads to beta cell toxicity through autoimmune process. So you have this autoimmune process by T helper cell mediated that will lead to secretion of cytokines and macrophage activation, which will ultimately lead to beta cell destruction. So the progression of type 1 diabetes, so you have this trigger environmental causes, and then you have beta cell mass with the genetic predisposition. You have the progressive destruction of beta cells when it reaches a critical stage of about less than, so 75% of the beta cell mass destroyed, or slightly more, 85%. Then you have little bit remaining of the beta cells, and this will make the patient a patient of frank diabetes. Before that, before the diabetes become overt, some of the remaining beta cells will try to compensate in a honeymoon period, which may progress up to 1 to 2 years. Usually it takes about few weeks to happen, but a few weeks to few months. The longest reported in the literature is up to 2 years. And in this time, you have progressive impairment of insulin release. So this is a period of impaired glucose tolerance. But when you reach this stage of considerable loss of beta cell mass, then frank diabetes appears. And then in that time, you need exogenous insulin supply. But this is just telling you that type 1 diabetes is very prevalent and with a high incidence. This is an old report, okay, in different countries, including Sudan, Saudi Arabia, okay, Finland, and some parts of Australia and North America, and especially in Canada. And it can be underreported in some areas, like in Africa and Middle East, but that's why you have higher numbers in Australia. These are some old reports. They are more recent ones. So this is an interesting graph. So projecting the future of diabetes population size and related costs for treating them in the US. And what's interesting about it is that those who are diagnosed at these years are expected to be lost earlier, but you have increasing cumulative incidence of the disease, not necessarily with the same patients, but with new patients that also expires earlier. So it's not a simple disease. and also increasing in incidence and putting a burden, financial burden in these communities. This is King's College in Cambridge. So management goals is to prevent death in these patients, alleviate symptoms, and to achieve biochemical control, so good glycemic control. And this will be reflected in pediatric patients in growth and development, and to prevent acute complications such as DKA and hypoglycemia, and prevent and delay late onset complications such as in the eye, so micro and macro vascular complications, eye, kidney, and central nervous system. So the management components include insulin and support in terms of education about carbohydrate counting, insulin carb ratios, self-care, testing injections, hypo management, sick day roles, psychological support, okay? Any patient with chronic illness requires this, especially receiving medications by injections, and your reviews in terms of examination, including microfilament examination for the peripheral neuropathies, and investigation, including blood and urine investigation, and eye examination. So fundal examination and lifestyle monitoring in terms of diet, exercise, etc. Okay, sensible exercise. Again, okay, you need obviously in terms of insulin, you can use regular insulin اللي هو الصافي versus MPH هو العكر اللي هو intermediate acting insulin called MPH. So you use it in a ratio of 1/3 and 2/3. So 2/3 for MPH and 1/3 for the regular. Analogs, so different analogs, so mixed type of insulin like Novomix 30 or Humulog 25, ultra short like Novorapid and Humulog, Detimir or called Levimir and Glargine, and these are the long-acting insulins. So the insulin analogs are synthetic insulins, while the regular and MPH also synthetic, but some of them can be animal insulins. The analogs are similar to insulin structure, and with additional detergents can have different durations of action and start of actions. We will see that in subsequent slides in the graphs and in tables to see when the insulin starts to work and what is the peak, when will be the peak, and what is the duration of action. So just be familiar now with the names. You have regular and MPH, الصافي, regular, MPH العكر, and then you have, before you say the mixed, let us talk about the ultra short. The ultra short is, we have three main companies. So we have the Novo Nordisk. So all the Novo, okay, named insulins are after the name of this company, Novo, Novomix, Novorapid. Novorapid is a rapid one. Novomix is a mixed one. So you have Novomix 30, it means that 30% of it is Novorapid. And intermediate, like MPH is 70%. Okay, you have mixture between the regular and MPH as well. It's called mixed tart. So this is an Actrabid. Regular is also called Actrabid if it is prepared in a pen. So Actrabid and MPH. This is a mixed tart 30. The Novo Mix 30 is the Novorapid with MPH. Okay, so it's a long acting or intermediate acting. So, and then the second company, Novo Nordisk, you have Eli Lilly. And Eli Lilly is a producer of all the Humulog. So you have Humulog 25, Humulog 75, Humulog 50. So you have Humulog 25, Humulog 50. So 50, it means that 50% is rapid, ultra short, and 50% is intermediate or like MPH. And Humulog 25 means 25% of it is rapid, and the 75% is like MPH intermediate. And then we have this long-acting, اللي هم flat type in function insulins, the glargine, which is a lantus. Glargine is a lantus. Detamir is a levemir. These are the trade names, lantus and levemir, and these are the chemical names, detamir, glargine. Okay, the novorapid, the chemical name is aspart. Novorapid, the chemical name is aspart. Is the homolog is homolog is what is it called? The chemical name of it, Lispro. The homolog, the chemical name is Lispro. Right? And then we have the company that produces Lantus also have a rapid insulin. It's called Apidra, insulin Apidra. Insulin Apidra. Right? Apidra, the chemical name of it is difficult. It's called glycerine. Glycerine. So the trade names are more famous than the chemical name. Aspart هو novorapid. Lispro هو الهيمولوج. وابيدرا اللي هو apidra, this is like novorapid, the trade name. Glycerine, the chemical name of it. والcompany اللي هي producing glycerine or apidra هي نفسها producing lantus, والنيم بتاعها اسمها ايش؟ اسمها سانوفي افنتس. سانوفي افنتس هي French company. So we have اثنين American هم ليلي ونوفو نورديسك, and we have apidra, Sanofi Aventis اللي هي producing the Lantus. Now, most recently, غير Lantus عندنا واحد long acting that works for longer than the Lantus, اللي ما 24 hours, 48 hours up to 72 hours, اسمه تريسيبا. تريسيبا. واسمه الكيميكال ديجلوديك. ديجلوديك. طيب ديجلوديك هو التريسيبا. So Tresiba equivalent to Lantus, Degludec is equivalent to Glargine. الاسم الكيميكال بتاعه. Again, there are 3 long acting: Levemir, Lantus, and Tresiba. اللي هو Detamir, Glargine, and what? And Degludec. واضح كده؟ المستخدمين أكثر شيء هم النوفورابيد واللاندوس. طيب والميكس ميكس ستار 30 ولا نوفو ميكس 30. احيانا هيمولوج 25. Then if it insulin pump, the other name of it CSII, يعني continuous subcutaneous insulin infusion. You can have an open loop or closed loop. Open loop معناها انت introduce the blood sugar to the pump phase from a test, and you tell the pump how much you're going to eat in terms of carbohydrates. Closed loop, انه في sensor continuously talking to the pump and tells the pump how much the blood glucose now. So when you tell the blood glucose level, so when you tell the pump how much you're going to eat, immediately the pump will match this with the glucose level, serum glucose level, and will elect you to confirm an insulin dose. Or sometimes it can pass it through itself, so it's completely a closed loop system. Smart pumps can hang up giving insulin now and can give extra insulin from the basal rate if it feels that the blood sugar is going in a quick high rate or going down very sharply. So it has alarm system and can also be set to levels where it can hang up giving insulin or giving extra doses of insulin. These are called the smart pump, a real closed loop system. Okay. Homolog قلناها احنا. تابع يا مروة. I cannot repeat the things, and I repeat, I speak too slowly. And I speak far more faster than this. لكن I'm speaking slowly عشان to catch up. Homolog من الالترا شورت رابيد تابع لإيلاي ليلي. Homolog تابع لإيلاي ليلي. طيب يعني هو شوف التوبكس في الدايابيتس كثيره كويس. we cannot cover everything يعني from cystic fibrosis الاشياء دي اقروها انتوا من عندكم، لكن احنا بنشوف ال most important topics اللي بيسالوا منها كويس. we cannot cover everything in diabetes, it's not a simple topic يعني. طيب الان احنا before we go to this one, hold on, concepts. في some concepts during management needs to be emphasized, especially for newly diagnosed patients. تمام. I mentioned about the genetic component. I said there is a genetic, environmental, and other. Yes, in the counseling. I answer your questions at the end. كويس. فلا خلينا to run through the most important concepts اللي هي when you come and counsel a patient about type 1 diabetes. طيب. Obviously, if you come to see a patient who's newly diagnosed, if this patient was in DKA, you have to explain what was going on or what is currently going on if the patient is receiving a lot of IV fluids. So if you have to explain that, sometimes a classic example will tell them that the patient's body is like a car, and then you have the key of the car is insulin, and the fuel is blood sugar, and the engine is like the cells of the body. So you need this key is to switch the engine on and open the door for the fuel to get into the engine. And then this is exactly the job of the insulin, that open the door for the insulin to enter cells. And if you don't have enough insulin in the cells, then the body will change into catabolic state, because we look for an alternative fuel, burning the fat instead of glucose, and this will result in accumulation of ketone bodies, and these are acids, because you have two of them are acids, acetoacetic acid and beta hydroxybutyric acid, and you have acetone as well. So the breath will smell acetone, and the beta hydroxybutyric acid will be the first to be detected in blood, and then it will change into cetoacetic acid, which is detectable in the urine. So when we come and treat these patients, we wash these ketones and these acids out by IV fluids, and then we give IV insulin in order to switch it on for the engine of the body, so we get the glucose inside the cells, and then the body will stop burning fats. And by this, you will switch the body from catabolic state into anabolic state. So the body will start consuming glucose. So this is a simple explanation of DKA. And when you explain this, the parents may need to actually to be reassured that they are not the cause of diabetes in their child, because they always have this guilty sensation. And usually the symptom of having the child eager to eat sugar more than usual is a symptom of decompensation, and that the body is hungry for sugar. So the cells do not taste this sugar, which is in excess in the blood. And that's because it's lacking insulin. So if you have this cellular hypoglycemia, actually this can result from the outside or the serum hyperglycemia, because you don't have insulin, then you have the person feeling hungry for sugar. And they're classically eating more sugary things and sweety things before presentation. And that's not the fault of the parents. And this eagerness to sugar improves when they start receiving insulin regularly. Another question in their mind is that how frequent this can be inherited. Obviously, if you have twins, the inheritance is very high. It's about 30 times above the general population. And if the father is a diabetic, then it's 10 times more. And if the mother, it's less, it's about 2.5 to 5. And if it is a brother, then you have 7 times more than the other population. So they also ask when we can go home. And obviously we keep them until they learn how to inject, so as not to come back with a DKA, and not immediately after resolution of DKA and newly diagnosed because they can have relapse and recurrence of the DKA. So they need to stay for at least 24 hours in order to assess their insulin requirement and change them into subcutaneous insulin. If it is a known patient with diabetes and get into DKA, then the cause is usually one of two reasons: either missing the dose, the insulin, and that happens in adolescents when they experiment themselves without insulin to see how it goes, or if they have a severe infection, so insulin requirement of the body is increased. So in that case, when they switch off from DKA very quickly and they can be sent home at any point when they are much better and stable. So also you introduce different members of the diabetes team. So you explained about DKA, you told them about the habit of eating sugar and why is that happen. And you tell them about the inheritance of diabetes, and you also talk to them about when they can go home, and you tell them that they may have a period of partial remission or honeymoon period that we talked about earlier. It doesn't happen in every patient, but if it happens, doesn't mean that the first diagnosis was wrong. Then the Somogy phenomenon and Dawn phenomenon. Somogy, these are popular to ask about when we have analogs now started to disappear. And we don't see them a lot. Like they are more typical is MPH and regular, Safi Babiker. Because the Babiker is prolonged in action, بيشتغل about from 6 is up to 12 hours. So the 6 hours is the peak of it. So if you have it in the evening, there is risk of hypoglycemia during sleep. So if there is hypoglycemia at midnight, this will be compensated by dawn hyperglycemia when the patients have secretes counteracting hormones like growth hormone and cortisol in response to this hypoglycemia. So the treatment is to prevent this midnight hypoglycemia by reducing the dose of insulin, and this will reduce the hypoglycemia. Then you don't have a rebound hyperglycemia under the effect of counteracting hormones in the morning. The opposite for dawn phenomenon. If you have subdose in the evening, then obviously the insulin will not be sufficient to counteract the ordinary physiologically secreted hyperglycemic hormones in the morning. These are the growth hormone and cortisol, and this is called dawn phenomenon. So the treatment for this is to increase the insulin dose, and this will counteract the morning, ordinary secreted morning hyperglycemic hormones. So in dawn phenomenon, you increase the dose. In Somogy phenomenon, you reduce the dose so as to not to end up with night hypoglycemia that is compensated by hyperglycemia in the morning. But both of them present with hyperglycemia in the morning. In order to know whether you had Somogy or dawn, then you check the blood sugar at midnight to see whether the patient was hyperglycemic at this point or hypoglycemic. These are, as I said, popular to ask about in exam, but they are not observed in real life a lot. Sick day roles is that when the patient is sick, the patient needs to be checked frequently for blood sugar, 2 to 4 hours, and check for ketones, plenty of fluids to wash out any ketones, and also to receive and to continue having insulin, except for very young patients or those who have diarrhea and vomiting, not keeping anything down. But most of these patients are stressed and they have a lot of cortisol on the board, and the cortisol is hyperglycemic hormone, so it needs to be counteracted even if the patient doesn't eat. So you may end up needing extra insulin, or at least the usual dose of insulin frequently, so don't get into the habit of omitting insulin unless you observe hypoglycemias. If you are not able to get on top of things, then you need to turn up to the hospital. But now we talk, so these are the guidance you give to, these are the guidance you give. Am I sharing the screen? You can see the screen, huh? Guys, can you see the screen? Najid did not check that. Clear, خلاص, ممتاز. طيب. So let us talk about diabetic ketoacidosis. This is one of the complications, the acute complications. We already mentioned that this can, hold on just 1 minute. Come in. So as the name implies, this is diabetic ketoacidosis. So you have acids, accumulation of acids, and you have ketones, and you have the diabetes. And obviously, that's why this will define the condition biochemically. So biochemically, you have diabetes, so hyperglycemia, blood glucose above 11.1 millimole per liter, and pH, this is acidosis, less than 7.3, and bicarb less than 15. So it is acidosis with loss of bicarb, okay, and accumulation of acids. So the acids are the ketones, which are detected in the urine or blood. So preferably in the blood is the beta-hydroxybutyric acid. In the urine, usually tells you about 4 hours back because the bladder is a reservoir, and it tells you about 4 hours, the situation 4 hours ago. So, and beside that, you have symptoms. So the patient will be acidotic in respiration to compensate for this metabolic acidosis. طيب, يعني if they ask you the diabetes, soon inshallah all recordings will be what? Okay, this is Muhammad. Okay, طيب. Muhammad is announcing to you that the recordings will be available later. So for those who did not attend. طيب لو يعني if I ask you what do you call the breathing in diabetic ketoacidosis patients? Cosmal. Very good, Ibrahim. Ibrahim Mukhtar. طيب, cosmal breathing, if that's acidotic breathing or alkalotic breathing? This is an interesting question. cosmal. طيب. acidotic. طيب, ده مين ده؟ اللي قال acidotic أول واحد ده مين؟ إبراهيم في ديانة وفي وديان سوري أروى. طيب أوكي سكينة كلهم قال أسيدوتيك. طبعا في الكتب بيكتبوا لكم أسيدوتيك، في معظم الليتريتشر مكتوب أسيدوتيك، لكن أنتوا يو بليف إنه ده أسيدوتيك ولا يعني؟ طب إذا عندك ميتابوليك أسيدوز أنتوا مقتنعين إنه ميتابوليك أسيدوز صح؟ هو ميتابوليك أسيدوز ولا ريسبيراتوري أسيدوز؟ الأسيدوز في الديك إيش؟ أساسا metabolic. You're right. Metabolic لأنه accumulation of these acids metabolically وبايكارب loss of bicarb in the kidney مش كده؟ طيب فإذا هو metabolic. طيب why they call the breathing acidotic؟ مع إنه هو compensation للmetabolic acidosis بريسبيراتوري alkalosis مش كده؟ السؤال arbitrary شوي عشان ما نطول، كونوا تعبانين ذاته وانتم من العمل. هو this is actually arbitrary terminology. It is actually respiratory alkalosis. It is not acidosis. لكن they call acidotic breathing باعتبار الكوز، يعني the cause of it was acidosis metabolic. However, this breathing, this sort of breathing is alkalotic breathing. والcosmal breathing respiratory is alkalotic one، لأنه هو أصلاً أنت لو جيت توصفه الآن هل هو deep sighing respiration? It is not deep sighing. يعني the real acidotic is the Chinese talk, which is like this. These are the patients, septic patients in PICUs, whatever, you see them this way. When you see patients breathing rapidly and shallow, this is the وصف الcosmal breathing. Okay. This is washing out CO2 rapidly. So this is an alkalotic breathing, and it happens in all types of metabolic acidosis as a compensation. عشان كده بيحصل في الorganic acidemias and metabolic conditions, and they are misdiagnosed as respiratory infection in babies in neonatal departments. So this is one of the differential, and this patient is not actually does not have pneumonia, but this patient is running a respiratory alkalosis. So it's a common presentation of metabolic acidosis before the other features appear sometimes. So that's why it's called acidotic breathing, to tell people that there is acidosis behind this. Okay, dehydration, because I lose water, drowsiness, and abdominal pain and vomiting. Dehydration because significant, because water is 50% of, or more than 50% of our weight. Okay, abdominal pain, Benjamin, accumulation of acids, ketones, and vomiting also. This can be due to gastroparesis, and all, which is common autonomic feature in diabetic patients and can occur also as a result of accumulation of ketones. One of the complications that are poorly understood how it happens pathophysiologically is cerebral edema. So it should always be at the back of your mind when you are treating diabetic ketoacidosis, and it's a cause of mortality in 25% of cases. Hypokalemia can also occur during the treatment with insulin. So this is preventable. It's careful monitoring and management. So just while I'm talking to you, I'm on call. So I've been called about a patient who have hyperkalemia, but they think this is a squeeze sample because the patient is difficult to bleed. However, the creatinine was high. So in that case, that means this is a genuine hyperkalemia, and it can occur with pre-renal impairment when you have the patient severely dehydrated and present with DKA of severe or moderate degree. So in that case, you should be careful of giving or adding potassium to the fluids, and you should allow for the insulin as a good treatment for hyperkalemia to shift the hyperkalemia or the potassium inside the cells. And you should not add potassium to the management of a patient with a pre-renal insult or renal failure until the potassium starts to settle and the renal function is better. Aspiration pneumonia is something also. I have a story, different stories. If I keep telling you the stories, you may not finish the session, but I have a patient before in Edinburgh, about to be in Cambridge. Before discharge, I was the registrar. The nurses kept nagging me that they need to discharge this patient, that the patient need a review. When I came, I found that the patient vomited a lot, 20 or 25 times. So I suspected that this patient had gastroparesis or something, and we are worried that possibly he ruptured his stomach or developed aspiration pneumonia. So we put an NG tube, and because this is really a risk of aspiration pneumonia if you have a vomiting child, he's semi-conscious or not, or a bit drowsy. And actually that patient did not have any ruptured esophagus. That was just an autonomic feature of gastroparesis that can occasionally happen. And it's one of the risk of recurrence of DKA. Okay. Good. So that's the DKA, and I didn't go through the management of DKA. I think I have it in another talk. Let us talk about the outlines of management of DKA. The outlines of management. ممكن تكتبوا لي كده نشوف حد يكتب the outlines of management. 4 main components. Fluid, IV fluid, very good. Insulin, very good. ABCs or monitoring, very good. Electrolyte management. ما في حد كتب لسه potassium, very good. خلاص. دي الأربع أشياء كويسة اللي هي fluid, insulin, electrolytes, and monitoring. تمام؟ So with regards to the insulin, في the young age group, you start with 0.05. كويس؟ ما 0.1, 0.05 unit. كويس؟ يعني per hour, 0.05 mil per hour. You put the concentration 1:1, the units to mil. In different ways, 50 or 500, whichever, and you give 0.1 كويس unit per kg per hour, or 0.3 اللي هي نفسها 0.1 mil per hour هتكون كويس 1.1 mil per kg per hour أو 0.05 mil per kg per hour في the young age group. As well, potassium, you don't give it if the patient is in renal impairment, but you put it in a ratio of the ordinary one, which is 20 millimole per liter in 500 or 40 in 1000. Phosphate usually is deficient, but you don't compensate for that. Bicarb, usually you leave it for the most senior person to decide about this. So it's usually discussed with the PICU team. If the patient is hemodynamically unstable, then you need to give, usually you give half correction rather than full correction, because this will spontaneously improve with the IV fluids. And if you infuse the bicarb, this can lead to some toxicity after that when it corrects itself spontaneously. So it's one of the predisposing factors to cerebral edema, to be too enthusiastic about the bicarb. And also, if you drop the blood sugar too rapidly, change of osmolality is thought to be a cause of cerebral edema, and also it's rapid change in sodium. So it's now universally agreed that when you give IV fluids, you shouldn't be too generous. So they have a special regimen in some tables instead of the routine ones, or you can use the routine ones, which is 100 ml per kilo for the first 10 kilograms, and then 50 ml per kilo for the second 10 kilograms, and then 25 to 30. So be on the downside usually with diabetes. And when you give them this, you try to avoid boluses if they are unnecessary. And then you add to this, what do you add to it? The deficit. And you assume all the patients with DKA have severe dehydration, not a moderate one. And the severe is usually 10 to 15% of the body weight. And what is the easiest way to calculate deficit? How do you compensate for deficit? واحد يكتب لي equation ولا الديفيسيت. بس احنا كلامنا على المينتنس. weight times 100 times 100 بس كده 100 ml per kilo. لا ده maintenance. 100 ml per kilo, 100 ml for the first 10, 50 ml 10% dehydration. كيف ده والله ما صحيح الكلام ده كله، ما صحيح. شوف انا اديكم قاعده في الفلويدز، دي عامه في الفلويدز في البيدياتريك ان جنرال. خلاص take 10% dehydration. لا listen to me, listen over 48 hours. ده كله كويس، ده كله كويس. خلينا اديكم القاعده في الفلويدز. في الفلويدز what you need to give during DKA، خلاص stop writing, listen to me. if الان when you want to give كويس fluid as a maintenance لاي patient, not a diabetic patient, you give for the, if you have a 30 kilos child, you give for the first 10 kilos 100 ml per kilo, صح? And 50 ml per kilo for the second 10 kilos, and 25 to 30 ml per kilo for the subsequent. يعني تاني لو في أوزان 10 5 20 كله تديه 25 ml per kilo. متفقين على دي؟ على المينتنس دي؟ Write to me that you are following me well. Okay? تمام. How much you need to give زي ما زميلكم وزميلاتكم قالت 48 hours. So you multiply the amount دي 2 times. يعني 2 maintenances. طيب؟ دي نفس الطريقة. طيب دقيقة لسه أنا ما جيت له. رفيدة اصبر شوية. كويس؟ This is what I mentioned. This is twice. كويس؟ So you multiply this by 2. كويس؟ if you multiply this by 2, then you are giving 2 maintenances. يعني 48 hours amount over 48 hours. كده كويس؟ You add to this the deficit. الديفيسيت ده ما تستهين به. خلينا في مثالنا نفسه. كويس؟ ما تفتكر الديفيسيت ده شيء بسيط. الديفيسيت ده هو ممكن the one which is risking the precipitation of cerebral edema. لأنه الآن لو حسبنا، أحسب الآن مثلا بس 24 hour ما 48 hours maintenance ل someone 30 kilos، أحسب الأولى 100 والثانية 50، معناها دي 1500 صح؟ زائد العشرة الأخيرة 30، بقت كم؟ 300. 300 زائد 1500 دي كم؟ 1800، مش كده؟ صح ولا ما صح؟ 1800 مل. You want to give it in 24 hours. صحيح؟ لو ضربتها في 2 you give it for 48 hours. طيب شوف الديفيسيت كم؟ الديفيسيت الإيكويشن فيه كالآتي. You multiply the percentage of the deficit times 10 times the weight. كويس؟ يعني 100 مل بير كيلو اللي كتب اول 100 مل بير كيلو حسبها من عنده، ده صحيح كويس، لكنها دي حسابها كده. يعني انت لو قدرت تدي واحد 5% ديفيسيت هتديه كم؟ 5 times 10 times the weight. كويس، this is a lot طبعا، مش كده؟ فاف يعني الان 10 times 10 is 100. This is like all the amount you give it for the first 10 kilos of his body. طيب ف 10 times the weight will come with a large volume, and if you add this large volume كويس اللي هيطلع 1000 هسه. هو الويت بتاعه 30 اكثر من 1000. 30 لاحظ 100 زائد 30 يعني تضرب في 30 3000. يعني الديفيسيت ده الان اكثر من المينتنس، قدر المينتنس ده مرتين. يعني الديفيسيت انت لو اديته في 24 hours it will give this patient the 2 maintenances plus، كانه اديته حق 2 days وزياده. and this is why you add this maintenance اللي هو 10 times 10 اللي هو severely dehydrated بقت كم؟ 100 في 30 3000 تضيفها لل 1800 وتضيفها ل 1800 ثانيه وتقسمهم على 48 hours. and by this you divided the 3000 over 2 days، كانك قسمتهم لشنو؟ ل 1500. واضح كلامي ده؟ Are you following me؟ ولا عيد شيء فيه؟ زي لايك هاف ديفيسيت. واضح؟ اذا شنو؟ اذا هنا ده كثير جدا، عشان كده الديفيسيت ده هو اللي you need to be careful. What do you deduct from this؟ تحذف ايش؟ ما واضح، بدي قاعد ما واضح في ثاني واحد قبل. طيب انا قلت انه الايكويجن للديفيسيت هي 10 times the percentage of the deficit اللي هو اذا كان 10 تضرب في 10، اذا كان 5 تضرب في 5، واذا بتحسب الديفيسيت 15 تضرب في 15. يعني حيبقى 10 في 15 او 10 في 10 او 10 في 5، وتضرب المجموع ده في الويت. ده هو الديفيسيت. يعني كانك انت فقدت 5% of your weight، 10% of your weight. You compensate for your weight 5% of your weight water او 10% of your weight. عشان كده بيطلع كثير اكثر من المينتنس اللي انت for the first 10 كيلو تديها 100 مل بير كيلو. كويس؟ وفور ذا سكند تديها، يعني انت عايز الفيرست تديها الفيرست 20 كيلو اوف يور بودي بتديها 1500. دي ثابته لاي بيدياتريك بيشنت. ولو في واحد وزنه 30 الديفيسيت عنده 10 في 10 في 30 3000 كثير. So if you want to give this 3000 in 24 hours هتكون كميه كثيره. معناها هتعمل ايش؟ معناها هتضيف الديفيسيت ل 2 maintenances و to give it over 48 hours. النص المينتنس ما بيتغير، ده المينتنس فور ذا فيرست داي والمينتنس. في ناس طبعا بيدوا للمينتنس كله فور ذا فيرست داي 80 مل بس بير كيلو، ما يضيفوا على كده. يعني مش يدوا 150 يدوا بس restricted amount of fluid. لكن المشكله الكبيره هي في الديفيسيت و how rapid you give the treatment. So برضو a type of fluid you give. The type of fluid is important. يعني لو انت السلاين a change in saline طبعا في a lot of physiology في انه الصوديوم كويس، يعني with the dehydration بيكون في false hyponatremia نقروا عنها هذه في DKA. فانت الان when you change the sodium you try to maintain 0.9% for the first 6 hours او مرات 12 hours 6 hours ما تغيره. عشان شنو؟ عشان ما يتغير يحصل رابيد شيفت وتشينج ان ذا صوديوم ليفل، لانه دي واحده من البوستيوليتنج ثيوريز اوف سيربرال اديما يقولون احنا ما معروفه هي بتحصل ليه. فخلاص بيقولوا because of the rapid glucose change. عشان كده لو الجلوكوز ريت اوف دروب is more than 5 مليمول بير لتر اللي هي 5 بيساوي كم؟ بالمليجرام 90 يعني قريب 100 مليجرام بير ديسليتر او 5 مليمول بير لتر نزل less more than that per hour, then you have to change the dextrose in the fluid. يعني انت لو بديت ب 0.9% saline only ولقيت الرابيد دروب في الجلوكوز، السيرب جلوكوز ماشي بالسرعه دي اكثر من 5 مليمول بير لتر per hour، then you add dextrose تخليه 0.9% and 5% dextrose. ولسه انت عاوز تواصل بالصوديوم في الفيرست شنو 6 hours. لو عدى من ال 6 hours الصوديوم برضه بدا كويس يكون يعني reasonable stable, then you can change to 0.45% and 5%. لو الجلوكوز نزل بسرعه 5 مليمول نزل في الجلايسيميك هايبوغلايسيميك ريت رينج 4 تعمل ايش؟ قد يدو كويس يا اسلام. You put the equation جزاك الله خير for the fluid. انا عندي توك ثاني في الدبيس مكتوب فيها الكلام ده، لكن بس يعني mixture of talks هيلخبطكم ساكت، فانا احسن اقولها بس يعني. طيب اهو بعدين لو عاوز لو الجلوكوز نزل للرينج اوف 4 and less increase the glucose concentration. اسلام ممتاز. اسلام اسم مشترك، ممكن يكون ميل ممكن يكون فيميل ما اعرف، لكن المهم ممتاز whoever answered. كويس. محمد عبدين increase glucose برضه very good محمد. طيب الان why you increase the glucose؟ ما تنقص الانسولين، توقفه. الجلوكوز نزل، مش انت ده اللي عاوزه؟ انت مش you want to reduce the glucose concentration؟ ده المانجمنت، ده الايم اوف مانجمنت ولا لا؟ تديك ايه؟ to clear acidosis. ابراهيم مختار ممتاز. still acidotic مروه. لفظك ادق يا مروه. still acidotic is good. This is what we mean. يعني ايش؟ يعني لسه الجسم ما تعود على انه الجلوكوز صار هو السورس اوف انرجي الفويل اجين، المثال بتاع السياره اللي قلنا قبل، فلذلك still burning lipids out. فانت you want to switch off the catabolic process by insulin. عشان كده خلي الانسولين going and push more glucose، لانه الجسم ده جوعان للجلوكوز لسه ما satisfied to stop the breakdown of lipids. You need to satisfy the body to stop breaking down lipids, and this will switch the ketosis off. زي المفتاح بتاع النور، شفت you switch it on and off. If this is not switch off ادي concentrated glucose 12.5% مع انه جاب hyperglycemia وخلي الانسولين going. If you are really forced, you need to give something, give bolus of glucose. خلي الانسولين going. If you are really forced the insulin, keep dropping the blood sugar, reduce the insulin gently. يعني ما توقفه. إذا كان هو 0.1 unit per kilo per hour بجيب 0.05. أقل بجيب 0.025. Try to keep the glucose going on. طيب until you have the ketosis and DKA has stopped the ketone bodies production. Good. واضح؟ This is the fluid management. اتكلمنا عن الانسولين مانجمنت خلاص، يعني في نفس الوقت اتكلمنا عن الهايبوكاليميا مانجمنت، انك انت you have to add potassium الا في الكيسز اللي فيها risk of hyperkalemia. اتكلمنا عن الاسبيريشن نيمونيا ان دي تيوب to guard against gastroparesis والبايكاربون to give it. والمونيتورنج طبعا بالويت بالجلوكوز you have to do blood glucose hourly at least، ممكن في البداية more frequent. Electrolytes, renal function at least 2 hourly, and blood gas between 2 to 4 hours. Just to see whether you are, if you are in choice to have blood ketones or urine ketones, which one you will select? قلنا بدري blood ketones صح؟ لأنه الurine ketones will tell you about what happened 4 hours ago. So it doesn't tell you about the immediate situation. قلنا البلاد كيتونز هي الميجرد بالستريبس هي بيتا هيدروكسي بيوتريك اسيد، واللي ميجرد باي يورين هي اللي هي كم؟ اللي هي الاسيتو اسيتيك اسيد. هنا السؤال ده قال مين؟ عبير قالت after reaching concentration of how we decrease insulin. How we decrease insulin اصلا did not يعني we didn't talk about when to stop. طيب اول حاجه الانسولين انت you don't decrease it. If you don't need to you have to keep it, and you decrease it when you fail to compensate for hypoglycemia by adding more glucose. Otherwise keep it the same 0.1 أو 0.05 حسب ما أنت بديت. أصلا ما تلمس الانسولين. لكن يعني how to stop it when you are out of DKA. طبعا بالmonitoring you find that blood gas improved, the ketones production reduced or off. You don't need to be off completely. As long as you are not in the biochemical picture of DKA, you can stop the management. So the acidosis stopped. حتى مرات في patients بيجوك في الكلينيك أو في الER with DK without A، يعني ما في acidosis، في ketosis وفي uncontrolled diabetes but not yet built up acids. So the patient 7.29 يعني borderline acidotic أو 7.3. We started to have ketones. You can give extra dose subcutaneously and switch this process off. So you don't need to commit the patients to IV fluids and all the package of management. Your patient أثناء المانجمنت طلع من الأسيدوزيس وما زال عنده بعض الكيتونز. What you can do, you have to hand over the insulin treatment to the subcutaneous one. يعني إيش؟ يعني هو على ال IV fluids, you give him insulin. تمام؟ And then you wean the IV fluids off. طبعا لو اديته regular, you have to stop it after half an hour لأنه this is the peak of the insulin. It starts after half an hour. ولو أعطيته no rapid, after 10 to 15 minutes you can switch things off. لكن still الناس متعودين على شنو على half an hour. We have to be flexible with them. لكن في النهاية the insulin no rapid and rapid type of insulin can take over within 10 to 15 minutes and then you stop. طبعا تخليه ياكل حاجة وياخذ subcutaneous insulin, then you switch off the IV insulin. IV fluids, it depends on how much dehydrated he was, so you can carry on his dehydration with fluid if you wish, and if it's preferred to continue with saline only, then we started to have subcutaneous insulin for the glucose now. This is how to come out of DKA. إذا البيشنت جاء يعني بالليل وانتسيبيتد إنه الصباح يطلع من DKA, in order not to live without basal insulin during the day, you better give him the Lantus or the basal insulin during the DKA management بالليل. And this will help him to be on basal type of insulin after DKA treatment is discontinued. نتكلم حنجي ثاني عن عارف عندي حته ثانيه فيها الديكي حنجي على الانسولين اساسي hypoglycemia. طيب theory behind starting insulin 1 hour later after starting IV fluids. Theory شروق good question لانه احنا we don't know the pathophysiology and it's thought انه في a lot of things that can correct by rehydration. So before you commit yourself زي منها البايكارب اللي انا قلت لك ده انك انت في a lot of low bicarb كويس يعني by replenishing the circulation زي ما قالت إسراء you will improve these things. Or if you jump rush to correct them, well, insulin correct some of them منها الجلوكوز يعني part of the hyperglycemia because of dehydration. If you shifted rapidly by the insulin in the state of dehydration and then you have the rehydration, the rapid rehydration, this can result in cerebral edema. So this is one of the measures to guard against cerebral edema. As most of the theories اللي بتحصل في المانجمنت of DKA دكتورة شروق هي شنو؟ related to guarding against the risk of cerebral edema. ممتاز؟ طيب target blood glucose 4 to 8 millimole. هل هو ده الهايبوغلايسيميك رينج؟ يعني انت هسه لو عندك بيشنت ما ديابيتيك هايبوغلايسيميا من كم؟ من 2.7 يعني دي هي استدي قديمه WHO كويس بالذات في الجروينج برينز وكده في النيونيتس. لكن احنا بنستعمل 4 ليه؟ لانه this is a patient on insulin. So we want to train the body to feel the hypoglycemia when they are less than 4 before it comes to a risky range or dangerous range when they have dangerous hypoglycemia with seizures. So لو في patient feels jittery and pale and hungry less than 4 3.5 3.8 ما حيصل لي seizure يعني الا لما يصل low levels less than 2. لكن if you allow this to happen up to 2.5, you may end up with a patient who have seizure with this insulin treatment. And therefore, we put it that, and this is the opposite of hypo-unawareness. Hypo-unawareness and someone كويس ما عنده awareness of hypo لأنه he goes hypo frequently. Then he only feels the hypo when it comes to dangerous level. تمام? It's treated by oral or IV كويس insulin. The symptoms of hypoglycemia are fight or flight. اللي هي sympathetic one. So pallor tachycardia, sweating tremors, like someone who's going for an interview or exam or whatever, then they will have this sympathetic outflow. And also, some of these are neuroglycopenic. So you have headache, irritability, so glycopenia of the brain cells, nausea, seizures, tuberose, and coma. So the causes in diabetic patients can be missing or delaying the meal after the insulin, after the story اللي حكيتها لكم, أو exercise. more not matched well with the amount of carbohydrates taken and insulin, or alcohol in some societies, or overdose of insulin in some adolescents who experiment themselves to see how this could be effective or not, or impaired food absorption, so concomitant celiac disease. So you have insulin, but you don't absorb the food well, or other counteracting hormones that balance the action of insulin are not perfectly working, like Addison's disease. So treatment is oral carbohydrates like glucose tablets or gel or fluid. If you don't have these, then you can have the tamr, asal, the buccal area. You can give this, and it will be very efficient in absorption, and it's a high glycemic type of carbohydrates. IM glucagon should be prescribed for patients for emergencies until they have ambulance to take them to the access an emergency. And then when they arrive or during their journey to the ER, the ambulance can give 10% dextrose 2 ml per kilo bolus. And the management is the management of cause, and if you know the cause. We have an example, ما جبته هنا, like if a patient 14 years old, and had this hypoglycemia, and في النهاية conclusion إنها she was doing this as a part of adolescent behavior and experimenting herself. So everything was normal. So they've done the adrenal profile, celiac screening, and all come back as normal. And actually she's hyperglycemic with high A1C, but this is sometimes adolescent behavior. So let us talk a little bit about what is called intensive or optimized insulin therapy in diabetics. You need to mimic the physiological insulin replacement in patients and assess for glycemic control by the self-monitoring blood glucose and hospital testing on a periodic basis, so for A1C. And insulin dosage adjustment is actually an exercise or practice that should be entertained by the treating team and the patients and family at home. Healthy diet is recommended for everyone, especially for diabetics. And diabetes education is a cornerstone of the management of the optimized management or therapy for diabetics. So it's an overall system. This intensive therapy system is overall system to get the treatment or the insulin delivery to these patients optimized. I don't know, like recorded. I think it's recorded, yes. They told me it's recorded, yeah. It is recorded. Recording is going on. طيب في يعني cornerstone studies that has been influencing the management intensive therapy. These are طبعا DCCT اللي هو direct or diabetes control and complication trial, and then we have this UK diabetes. This is another large one, including adults. Type 2, type 1 is the diabetes control and complication trial. But then we have Komamoto. This is a Japanese study for type 2 as well. And then looked at the complications, and all of them concluded that the intensification of therapy reduced the risk of complications. So the elements of intensive therapy have multiple components. So careful balance between food, activity, and insulin doses, and also self-monitoring of glucose. There is no alternative of this. Without having the blood sugar, you cannot decide on this balance. We mentioned above that. And the patient adjustment, so they have some independence in doing this, equipped by information, not just a random guessing, and looking at patterns rather than one individual readings, defining the target blood glucose level, the individualized. So some patients may have risk of hypoglycemia. In some centers like Oxford, they monitor the good response by having the good response by having a number of hypoglycemias in patients. That indicates the patients are doing well, but not dangerous types of hypoglycemia to develop hypo unawareness. So good contact and rapport between the patient and the staff, education and motivation for the patient, psychological support, and annual assessment. So these are, let you read through these slides and share these slides with you. okay, through Dr. Muhammad, Insab Muhammad Al-Zain. And these are ideal and acceptable ranges. Yeah, you don't need to memorize this, actually. They're just good reference to keep في ال 2-hour postprandial and the preprandial levels of blood sugar. طبعا insulin يعني make a big difference in the management of diabetes. Patients used to die before the discovery of insulin 100 years ago. That's why they celebrate the discovery of insulin, and there is يعني every time progress and prosper in the ways you deliver it. So we have this pens that replaced the scary needles for children and even to adults. So you have the pre-filled pens like this with very small needle at the end. And then we have these pumps, and these pumps is also the Omnipod pumps, which is a wireless that talks by Bluetooth technology. And also we have the closed loops. So we have the sensors that talks to the pumps, and then it delivers the appropriate amount of insulin. So these are the smart pumps that guard against, and there are models of them. So instead of Medtronic View, we have also now Medtronic 640G and 780G. So there are some models of this. Acquicheck from Roche companies, or different companies working on this. And all of them try to mimic the physiology. So we have a basal rate of insulin secretion here, and then we have boluses with meals and with snacks, with major meals and also with the snacks. And this is a fluctuation of glucose according to the meals, whether it's a proper meal or just a snack. These are the rapid acting, short acting, intermediate acting, basal and premixed. I talked about them before, so I'm not going to repeat myself. This is a brand name, and this is the chemical name. Lesprospal, glycerine, glycine, diabetra. And then you have the humulin or humalog. So the regular, the صافي برضه من Eli Lilly. Anything you find humo, this is Eli Lilly. ومنه في novolin, so novo also have regular. And Relion, sorry, and MPH برضه بتلقاهم من Novo and من Eli Lilly. So these are the three major companies: Sanofi Aventis, and Novo Nordisk, and Eli Lilly. Eli Lilly is the oldest of them. These are mixtures of 70-30, 75-25. Sometimes the name of it is Humolog 25. They take this off. Okay. This is also how quick they start in action and when they peak and the duration. In general, the rapid type of insulin كلهم Lispro Asparto كده, they work for 46 hours. They peak at 2 hours or one and a half, from half to usually 1.5 to 2 hours, and they start working in 5 to 15 minutes. The regular, they start working half an hour to 1 hour, or it peaks at 2 to 4, or it can work up to 6 to 12 hours. MPH at 12, 10 to 20 with the peak بتاعه. And this is the Lantus, which is peakless, doesn't have. Detimer is semi-peaked, it's not a typical peak. Okay. So this is also a graphic representation of them, if you like this, and easier for you to remember the same ones, adding degludec to them, which is 24 plus, so up to 36 to 48 hours. Degludec has got a longer duration than the glargine. And this is, the structure of it. So by addition of few things, whatever, some amino acids, this will prolong their action or function. So this is a human insulin, and they're all just built in similarity because they're analog for them with the addition of some substances to make them working for longer duration. So this is head-to-head study, the degludec and the Lantus, and as you can see that the interpersonal and intrapersonal variations in Lantus is huge compared to degludec, which is more steady, so less risk of hypoglycemia, and this is called area under the curve. So it's much better with degludec compared to glargine. This is the same one I showed you earlier. Some people like the graphic representation more than the jadwal or table to show. So this can be helpful to them. So this is a Lispro and the rapid insulin, and this is the regular, which is, you call this ultra rapid, and this is rapid, and this is intermediate, and this is long acting. So principles of management انك زي ما قلنا communication, education, motivation, support, and these are the basic concepts needs to be emphasized اللي هي insulin sensitivity, the last one, the correction factor. Yes, when we correct for high levels of blood sugar apart from eating. وبالنسبة eating, you need to match the insulin to carbohydrates. So, and you need to know the different types of analogs and duration so that you adopt the basal bolus regimen. Few neonates sometimes are diabetic, so sometimes you don't need this basal bolus to be 4 times a day. So there are different regimens for the MPH and the basal. So you give it twice daily or 3 times daily or 4 times daily. Okay, and then we have the continuous subcutaneous insulin infusion, can be open or closed loop system with use of sensors. So this is an example of twice daily. If you have rapid insulin and intermediate, rapid and intermediate. So the day is finished here. So this is twice daily regimen. This can be a good option for people who need less injections or very needle phobic. However, the problem is this MPH at night can cause some hypoglycemia here because this is not associated with food intake. This is 3 times a day when you have the same regimen as we did before, but what you do, you give the intermediate here, and it covers, okay, the whole day, and then you just give 2 rapid in the middle. Sometimes you can give it, you give mixed rapid and intermediate, and then you give rapid in the middle as well. This is also a 3 times daily regimen. Or 4 times a day when you give a bolus, a basal insulin for the whole day, and then you give 3 boluses with meals. You may add to this snacks if you wish, but this is the standard is 3 times boluses with a basal for the whole day. And this is a multi-dose, this is the basal bolus regimen. So this is a basal bolus. You mimic you have the basal and you have bolus to match insulin with the prandial. So this is a prandial with the rise of blood glucose. Right. So and the increment of dose, something a little bit specialized. You don't need to bother yourself with that. But there is something interesting that we do the testing pre-meals, and this is called look-back approach. Right? So if you have a rise in blood sugar before lunch, that means the breakfast dose was not enough. If you have a rise before dinner, that means lunchtime was not enough. If you have it before sleep, that means dinner time insulin is not enough. So look back approach, so you increase the dose where you try to correct. So when you correct in the lunchtime, that means that next time increase the breakfast so you don't need to correct at lunchtime. And the other alternative is that sometimes during winter or summer, you may have a meal in the middle. So some people عندهم شاي المغرب وجبة حلا في النص وكده بين العصر بين الغداء والعشاء. So you may need an extra dose for that. So the rationale in the intensive therapy is not to restrict the patient freedom because of the illness, rather give extra doses and give this will give more freedom for the patient. If you have the pump, you just press the button, obviously. And this is how you optimize the dose in premix. If you have twice daily dose, then you look back approach also, and you reduce or increase by this if you have the blood sugar between this and that range. So these are the range of blood sugar you want to keep in the biphasic. If you have multi-dose or 4 times a day, you do the look back approach I mentioned, and you increase the doses according to this. So if you have the blood sugar as high as this level or that, then you reduce or increase the doses according to this. Yani by 4 units is a bit generous. You usually use 2 to 3 units only. We don't go beyond this. And we look at patterns. We don't look at 1 or 2 readings. Usually we look at the pattern in the morning, pattern after lunch, because the pattern tells you that this is a consistent a constant problem, not a problem that has a story. Because you may have hypo at one time, and the story for that, it was associated with exercise. مشوا البحر وبيلعبوا وجرى بعيد وجوا أولاد عمه وأولاد أخوه ما أعرف شنو، ولا بعدين مشوا عمرة مشى كان بيمشي وبيجري العالمين. دي كلها reasons for guys to get the blood sugar down, and it's a special day. It's not a routine day. Okay, you don't treat events, you treat patterns. If you have a pattern, then you work on that and you teach the patient that. This is a pump I'm not going to talk about that too much. And you match this with the meals طبعا. يعني this is the physiological secretion and these are the pumps here. And you have different basal. يعني البيزل ما بيكون في نفس المكان، ممكن يكون هنا فوق بعدين تحت بعدين فوق هنا basal هنا. Depending on your needs, whether you increase the basal or reduce it. So it has the advantage of changing the basal and have different rates for that. These are the sensors that can speak to the pump, electronic guardian, Dexcom, etc. You don't need to bother yourself too much with that. Right, with all this current technology of fast-acting insulin, long-acting insulin, okay, insulin pump therapy. نعيمة أجيك بعد شوية في نهاية السيشن لحظة، قربت أنتهي. والجلوكوز monitoring systems you have freestyle libre برضه عنده sensor الآن. Then and patient education and empowerment to change insulin doses is appropriately and discussed with the team, have an open access as well. في الcarb counting في حاجة اسمها DAFNI trial, is a dose adjustment for normal eating. So you consider things in exchange. يعني يقول مثلا 3-9 معالق رز دي بتحتاج 1 unit for this patient. So this is called in exchange. يعني you teach them carb counting in exchange amount. Insulin sensitivity, okay? So the patient will become more sensitive to insulin after a mobile activities and in the evening. وفي الصباح لما يصحى من النوم بيكون شنو more resistant to insulin. So despite all of this, few limitations still, and people have risk of night hypoglycemias. So they are looking for other alternative options for patients. So one of them is optimizing the insulin action, and therefore they get the degludec, which works for 72 hours or slightly less. That's useful in traveling patients when they travel long distances to Australia or America, whatever. And it's 14 hours, 13 hours. So you don't need to change the time of insulin a lot. The way, optimizing the way you deliver insulin, so this is through the pump and also the sensors and taking burden of injection and testing from the patients. Immune population and modulation, because at the honeymoon period or partial remission, if you work on the immunity and try to suppress it, this may suppress the destruction of beta cells, and this can help. And there are different trials trying to do that in France and different countries. So the challenges, this is my last slide maybe, is non-availability of insulin in poor countries. So the challenges are different across the world. Some people try to find new therapies, and some people may not find access to the standard therapy even. Whereas, or the way you store it. Sometimes you don't have the electricity، بتقطع الكهرباء في السودان كثير ودي مشاكل. الآن بيفتشوا ويلقوا طرق زي مثلا الزير الأماكن دي مكان بارد. يعني الناس بيشوفوا their local communities how things can be manipulated in order to keep the medication in a safe way and functioning well. Injection site and technique, this is something that needs to be reviewed by the diabetes educators or all diabetics, because if you inject frequently in one side, insulin is anabolic hormone, will lead to lipohypertrophy. Rarely it can lead to insulin or lipoatrophy in insulin resistance or allergy. I have a paper about that. You can Google it and you'll find it. Insulin storage and transfer, that's important. If they are going by whatever source of traveling, then they need to keep the insulin optimum temperature. Mixing insulin preparations, as important, you should not take the العكر قبل الصافي, because if you put back some of العكر في الصافي, this will disturb it and it will not become صافي and have the characteristic of this rapid duration anymore. So you should take the صافي قبل العكر. طيب وبيبدأ العكر آخر when you prepare by needle. Insulin and school hours important, so you need to have some help from the school staff and you need to plan it as well. So if you have children who are not supported at school, you better use the rapid. Sometimes you need 3 types of insulin, rapid insulin for the school time to cover, and then you use ultra rapid like Nova Rapid when they come back during lunch and dinner. Adjusting insulin dose at home. So this is empowering patients to do that. And because you only see them every 3 months or whatever, so you have to, and with the body changes, give them the skills how to deal with problems. Sick day management, you need to emphasize them and tell them when to suspect hyper or hypoglycemia and how to continue with treatment, as I mentioned before, and recognition of and treatment of hypo at home. Okay, thank you very much. Any questions? نعيمة رافعة يدها. عارف دكتور محمد معانا ولا لا؟ لسه.
ايوه يا دكتور امير.
الله يعافيك. معلش طولنا مع الناس زي شويه، طولنا عليكم كثير. الدايبيتس كثير.
لا it's good والله. It was very interesting lecture وان شاء الله هم يكونوا they have يعني benefit ان شاء الله from this one.
الله يجزيك خير. جزاكم الله خير جميعا، مشكورين. لكن نعيمة رافعة يدها كده، أعطيها فرصة أن تسأل سؤال. اللهم آمين وإياكم إن شاء الله. بارك الله فيكم. خلاص إذا نبقى على البلان إنه next time we will have the thyroid, the adrenals and the bone race, a session about that, and then I'll leave you with my colleagues to use your knowledge and اللهم آمين جزاك الله خير يا زمردة. I'll leave you with that to apply your knowledge. Try to study from what you learned. I will share the slides with you. ما عندي مشكلة أنا في sharing the slides. خليها مع دكتور محمد وأنتوا benefit from it. لكن ما تعتمدوا عليها بس تماما، أقرأوا برضو أشياء ثانية. لكن في النهاية if this helps you to do good educated guessing, we have a structured approach to topics. I'm more than welcome to read from it. ولو في حاجة ما واضحة text me or email me. إن شاء الله موفقين. جزاكم الله خير. Tips for exams? Yes, we can talk about tips. Safe. إن شاء الله. الله يجزيكم خير. معلش أنا I look tired لأنه أنا جاي من الصباح شوية، عندي عيادة كانت، وبعد العيادة مشيت فيصل التخصصي